take your seats. Let me tell you my ground rules. Please turn off your phones or put them on silent. When you are a speaker, you're going to speak for the allowed time. And if you speak 1 second more, I will cut you off. It's very valuable. In prior sessions, people ran 2 minutes, 3 minutes, 4 minutes. In my session, this is not going to happen. Session 5. We are starting the first talk with my very dear friend and distinguished colleague, Dr. Hadi Abu Hantash, who has been an exceptional interventional cardiologist for at least 25 years in Jordan, and who has left his fingerprints on the hearts of many people in this country. We look forward for Dr. Hadi to come and speak about left main PCI and its complications. You have 15 minutes and I'll cut you off.
Thank you very much, Ahmad. It's always lovely to have you with us, Dr. Ahmad. Thank you for the kind introduction. Distinguished guests, Ziad, welcome to Jordan. Khalid, Tammam, welcome to Jordan. And all of you, of course, are welcome to this country. I chose this title, Left Main PCI Complication. Why? Well, let me just tell you about an achievement which we are proud of. Jordan was voted the most distinguished chapter of the American College of Cardiology in 2021. The chapters of the international ACC count 44, and we were the most distinguished. And we are so proud of this achievement, actually. Thank you very much. Left main PCI. When we started angioplasty training, nobody was allowed to touch the left main except with a diagnostic catheter. We're not supposed to touch them at all. Things started improving, and these are the newest guidelines of revascularization to improve survival in chronic ischemic heart disease syndrome. It remains a surgical indication of a class 1 for severe left main to have bypass. However, in selected patients with significant left main stenosis for whom PCI can provide equivalent revascularization to that possible by CABG. You can do PCI, and it's class 2A. That's quite an improvement, Omar, compared to where we were before. But nothing goes without you experiencing little difficulties along your ride when you do PCI of the left main. Left main PCI complications can be plenty. I'm going to focus today on left main dissection, left main to aortic dissection, thrombosis, and perforation. I will skip the rest, but we can talk about them in the discussion. Let me just tickle you with this case I encountered last year. 64-year-old female, non-insulin-dependent diabetic, hypertensive, hypothyroid with New York Heart Association, class 2 dyspnea and exertion and chest pain. Classic chronic coronary syndrome by definition. Her echo showed mild MR, good EF, and no regional wall motion abnormalities. Some of you will wonder, why in the world would they do the coronary angiogram? She came from an outside Jordan. She saw so many doctors overseas, and here in Jordan. Why in the world she ended up in my lab? My friends, it's called faith. So my faith and her faith came together. She was so scared of having the coronary angiogram. Well, we tried our best. She did not want to do any nuclear test and a CT coronary angiogram. You're one of those ladies. So this is really scary when you look at it. Went radial, diagnostic radial 5 French, and for you who have good eyes, you can see dye hanging there in the left main. You can see it, right? And what happened is, I went to the left main, and for people who work with me very well, I don't know if any of the cath lab technicians are around, I never engage the left main without looking at the blood pressure. I never do that in my life. So you got to trust me. Her blood pressure was in the low 90s, which is her blood pressure normally. There was a dichotic notch there. There was no damping, no ventricularization. All what I was doing, listening to music. Bushelli was there in the room, which I like to listen to when I'm doing my cath. And I just injected a test of dye. And this lady went, huh? And she arrested. Yes, mystery? It's mystery. That's what happened. And we started CPR. and there was this dye hanging there. I would not waste your time with this case. We can discuss it in a different session if you want. So what happened to this lady? Was it a dissecting left main? Did I massively air embolize, which can be possible, but I mean, I didn't see nothing on the blood pressure tracing to tell me that. Was it an anaphylactic shock, a thermomatous embolization, coronary thrombosis, or God knows what happened? So, with you being tickled with this case, I'm not going to continue the case itself. Let me tell you what happens with left main. It's not an easy task always to do left main PCI. Please, for my young interventionists, it's not always an easy task. Yes, complications with dissection can happen in less than 1%. And yes, it can be type 1, which is just roofing with dissection or dissection involving proximal LAD or circ, which does not usually lead to death, and you can fix it with the stent quickly. But sometimes the dissection starts in the left main, goes backwards in the aorta, and that might get you in trouble if it extends beyond 4 centimeters in the ascending aorta. What causes most of our iatrogenic left main dissections? It's most of the times inappropriate catheter position. I will talk to that, about that in a minute. And deep intubation during balloon deflation. My friends, my young colleagues, allow me to tell you young colleagues, one of my young doctors in Jordan one time got so mad at me because I called him a junior cardiologist, and I felt so bad. But we were all junior at one time. I always tell my junior doctors, please don't deflate the balloon and pull it out without a fluoroscopy. It's something which is dangerous. Why? Because you deflate the balloon, pull it back, the guide just pulls itself into the left main, sometimes reaches a diagonal even. So please, please don't do that without fluoroscopy. So iatrogenic dissection can happen either going antegrade, or it can backward go retrograde. What do? You saw the dissection. What should you do? Please remember, resist the temptation. When you see it, you don't need more pictures. Don't keep injecting contrast. Don't do that. Just, you saw it already. Don't do it. Ask your technician to replay, and that will be more than enough. What happened here? Okay. So don't try to inject more. Place a coronary wire, a floppy better off. Remember, even a 5-fringe diagnostic catheter can undertake a 0.014-inch wire. So you don't have to always put a guide to get an access. The most important part, make sure you are in the true lumen. If you're not in the true lumen, use IVUS. And of course, you can solve the problem with stent. What sometimes happens too, look at this case which is reported here. A balloon in the proximal LAD, inflated, it ruptured. What happened? The ruptured balloon caused backward dissection into the LAD, the ostial LAD, back into the left main. Be aware of those when they happen. With a lot of us doing structural heart disease, nothing is always a safe ride, my friend, in interventions. This is a patient who had a sapien valve, 23. They decided to do post-deployment dilatation. And with the post-deployment dilatation, the patient hemodynamically collapsed, went into VFib, intubated. What happened? Left main dissection, extending into the LAD. But with God's blessing, it was successfully reversed with stenting. Left main dissection, most of the cases, you can really fix them so easily. It's not a big deal. If you take a breath, don't keep injecting, you solve the problem. The problem comes up, which scares the hell out of us, when there is a dissection in the cusp extending into the ascending aorta. This is from a right coronary, but it can happen with the left main coming backwards. What you do again, you see it, enough for diagnosis. Stop injection, place a stent at the entry of the dissection, and if there is an extensive dissection, which by experience and consensus is more than 4 centimeters into the ascending aorta, especially with the new aortic regurg, you must call Dr. Amar Lattouf to come and help you in the cath lab. This is really a scary case which was reported in the literature. They were doing a left main intervention, and they saw this dye hanging in the cusp and in the ostial left main. The patient arrested, they did a TEE. What do you say? Goodness sake, look at all of this thrombus clot in the aorta itself. Look at the massive AI which happened. A CT angiogram which was done. Look how big the hematoma is, and it compromised the ostium of the right coronary. It can be devastating. It can be devastating. This patient went to the OR, and even our colleague surgeons could not save the patient. Let me talk about ABC of what we do in the cath lab. A lot of people use the word damping and ventricularization as if they're the same. My friends, it's not the same. When you damp, you lose your systolic and diastolic blood pressure. That's called damping. So systolic and diastolic blood pressure loss, it's called damping. You damp because there is a clot at the tip of your catheter, or you are actually clogging the tip of your catheter by the vessel wall. That's what's called damping. And if you have an acute kink in your catheter, it will cause damping. What's ventricularization? Systolic blood pressure is maintained, but diastolic bottoms down. That's ventricularization. If you have a 7 French guide into the mouth of an ostium which can fit 6 French, you will ventricularize. If somebody has an ostial right or ostial left main, you will ventricularize. It's important to know this nomenclature to know what you're doing. I love this slide. Why do I love it? Because all of us, including me, sometimes forget it. Why? When you look at the left side, we look at this blood pressure, you think it's fine. My friend, it's not fine. When you see this without a dichotic notch, it's either you are filling the catheter with contrast, which is fine, but you can actually have big air bubbles sitting there, and you lose the dichotic notch. And you can have a clot in your catheter, and you lose the dichotic notch. This is what you like to see. This is what you like to see, especially when you engage the left main or the ostium of the right coronary. Now, let me switch to iatrogenic coronary thrombosis. It can happen. Why would it happen? You can inject it from the guide. If the guide is sitting there, the ACT, which you're not checking adequately all the time, you might have a clot there, and you might, by injection, let it go into the system. If this happens, which can be predicted by longer procedural time, complex procedures, and of course, if your ACT is not high enough. So keep checking ACT in complex situations. Khalid Tammam, who does a lot of CTO, tells you that they have a tick on timing. Let's check the ACT, right, Khalid? Everybody does that all the time. So if you have distal embolization with the clot, you thrombus aspirate, you can use G2B3As intracoronary, you can use T and K intracoronary, and of course, you can balloon inflate or agitate to disperse the clot. Now, let me show you this case here. It can happen while you are doing stenting of the left main. Look at the baseline distal left main. You did the provisional stenting, protrusion in the left main. Patient had chest pain, ST changes. You see this here, the ostium of the circ. There is a clot there, eccentric sitting there. Keep the ACT always high all the time. They did thrombus aspiration, G2B3A intercoronary, and balloon dilatation, and they reversed the problem. Let me finish with something which I can tell you none of you, including me, would like to have. It's left main perforation. Did anybody of you, frankly, have that? God forbid, I did not yet, but I'm sure I will. If you get left main perforation, it's a test of your resolve and your nerves, my friend. Why? Well, look at this case where you have the perforation here. You put a covered stent. Okay, covered stent. Where is it ending? Where is the circ going to go? How do you want to access it later? A covered stent has a high in-stent restenosis rate. It's a big problem. Coronary perforation management, I'm not going to go through that. You should know it by now. But let me enlighten you in those last 2 slides I have. This was given to me by Ahmad Shaban, who is a friend of a lot of us here. They looked at the usefulness of the gelled balloon technique during PCI when somebody has severe left main perforation. This is somebody who had a rotablation, ended up with perforation, and they put a graft stent. What they do, please remember this. I thought that I'll share it with you because I learned from Ahmad this trick. Let's assume you have a perforated left main. You want to put a covered stent there, okay? Keep a wire towards the circ and put a balloon there and jail it while you're inflating the covered stent. What that does for you, it keeps access to the circ for you to buy time. In my opinion, and I will listen to you and your experience and your prediction of this, if you put a covered stent across the left main to the LAD, I don't know how many of you will feel comfortable leaving this patient like this until the end of life, because things might happen inadvertently harmful to the patient in the future. So let me finish by the coming 20 seconds. So I covered left main dissection, which needs you to be handling the guides very carefully. You can manage with stenting, and if you can't, go to cabbage. Aorto left main dissection of the same. Thrombosis I showed you with anticoagulation. Keep your eye on the ACT and perforation. God forbid, hopefully none of you will encounter this problem in the future. With that, I would say thank you very much. Questions?
Okay, we're going to change the style of our presentation. We're going to give you 5 minutes for questions and answers, because by the time you leave, we're going to forget those questions. And I'm going to ask Dr. Ziad to lead that questions or conversations.
So, thank you very much. This was quite comprehensive. So what happened to your case?
I thought, Ziad, you will tell me that. Well, I don't have time really to show it, all of it. I lost a patient. I did everything in the world. I presented at the ACC Middle East. We did everything you can think of short of ECMO, which we don't have. I wish we had ECMO at the time. And even the audience, which we had at the ACC Middle East, we were like puzzled.
But you had already engaged the left main.
I went back, put a guide, put wires.
No, but when it happened, were you engaged with the guiding catheter?
No, that was a diagnostic 5 French.
You were engaged with a diagnostic 5 French. So there is a possible, and the patient came with ACS or something.
It's actually chronic stable type of syndrome. It's not.
I mean, you know, sometimes you do see a tight mid-left main. I mean, you don't see it because you close it before you see it, but that also is part of the differential. I mean, that's what we sometimes deal with.
I promise I'll share it with you, Ziad, next time.
Good.
Thank you for the nice talk. I think the worst we can see in the left main is the left main mid-segment perforations. This is the worst, and I'm worked a little bit in the area with laser to do a atherectomy, and this is a very common complication with laser. And if we have this kind of perforations and we don't have a good surgeon near us, because left main dissections or perforation is very quick, so we lose the patients very quickly. So I think it's, Dr. Ziad and Dr. Hadi, they have been working in an era with perfusion balloon, which should be, again, to our cath labs if we do this kind of complicated case. Or we do it in hyperat rooms, who has a surgeon be standby to open the patient immediately, especially when we have a distal very calcified lesion, which we're going with a very big, of course, shockwave, it's very nice tools now, we can do it, but sometimes even shockwave cannot go, so we need, and patient is very complex to go for surgery, and we have to go with rotablator or by laser. And when we have this kind of gush perforation in the mid-segment left main, we could not stop it. And we have to inflate long balloon until the surgeon will be ready to open the patient. So perfusion balloon, I think it's time to come back.
Khalid, this is a brilliant point, because you know the first thing which we do for perforation anywhere, you inflate the balloon at the perforation side. In the left main, if you inflate the balloon for a long time, the patient is not going to tolerate that. So you really, I agree with you, and I second you, you need a perfusion balloon. We don't have them anymore. You can improvise, but I don't, do you have it in Saudi, in Masr, in
No, but in Japan there is, because they're using a lot of lasers, so they have it. But I tried to get it in Middle East, I could not.
Yeah.
Just for people who are not familiar with it, this is a balloon that have pores proximal to the balloon in the shaft of the catheter, and then there are also holes distal, just distal to the balloon. So basically blood goes into the proximal holes through the balloon shaft and exits beyond the balloon. That's what it's used to. It's a Stack perfusion balloon. Stack from Duke, who invented this balloon. This was the days before the stent. We used to use it a lot because invariably with balloons we used to create dissections. We didn't have stents back then. So you do those prolonged balloon inflations to try to seal the dissection. And that was the purpose of it. Now in Japan, I hear from Khalid that they use it to seal perforations.
Thank you very much, Dr. Hadi, for this nice coverage of the left main stem catastrophic complications. Actually, we have one case in Iraq last year with a perforation of the left main stem, but the operator was very lucky because the wires are still in the circ and the LID, and he covered the dissection and perforation, and fortunately the patient was rescued. So if the wire is in the LID, the chance of avoiding this catastrophic complication is very high. Fortunately, most of the left main stem complication or iatrogenic dissection are preventable and avoidable. Thank you very much.
I think Dr. Hadi and dear guests, we're going to close this session with one final comment from me. I don't think in today's age it's acceptable not to have percutaneous mechanical cardiac support. I hope next year we will have a dedicated session on percutaneous mechanical support.
Thank you, Ahmad.
Dr. Hadi, thank you for the courage of presenting this case.
Thank you, sir.
You want to introduce the next speaker, Dr. Haitham Shawley?
Can you give me this?
Yes, so we will now move to, we'll invite Dr. Haitham Shawley to the podium to present on a long calcified lesion in the LAD.
Okay, I'm coming from, hello everybody, I'm coming from Haifa Medical Center, and I will talk today about a case of long calcified lesion in proximal LAD, proximate LAD. This is my disclosure. And as we all know, coronary calcified lesions are challenging for us, represent a challenge for interventional cardiologists. We have a higher risk of immediate complication, intra-procedural complication, and late failure due to stent under expansion and malapposition, and poor clinical outcomes. So a good characterization of calcium distribution and multimodal imaging, I think it's mandatory in order to improve the successful treatment of these lesions, like IVUS and OCT and maybe CCTA. And the use of traditional or new dedicated devices for the treatment of calcified lesion allow us to better prepare the lesion. And therefore, we should all know the different mechanisms and technical features and complications of these devices. Maybe it's time to mention that in our center we have the highest volume in our territory of rotablation procedure and IVL, intravascular lithotripsy procedures. And we have a case of 78 years old female with diabetes mellitus, hypertension, and the other comorbidities mentioned here, which is obese with morbid obesity and ischemic heart disease with a PCI to RCA. As you can see here with the recurrent PCI to RCA, the patient was admitted to our department with non-ST elevation and pulmonary edema and have slightly elevated blood pressure, tachycardia, and the ECG you can see is sinus tachycardia and T-wave inversion in pericardial leads. And in echo there was a mildly reduced LV function, a basal akinesis and anterior wall hypokinesis, and the ejection fraction was 45% and mild MR. Then we decided to move to cath lab, and as you can see here, all of her coronary arteries is diffusely calcified and heavy calcified. And you can see here also the circ is totally occluded, and it's known to be totally occluded from previous cath. Here you can see the right coronary artery, which is dominant artery, and it has two stents, patent stents in the mid and distal portion. And here you can see the LED with a diffusely calcified and long calcified lesion from the mid to up to the distal LED. All the LED is calcified. And then we stopped and asked, there was a discussion if to send the patient to CABG or PCI, continue to PCI or optimal medical treatment. So the LED was not a good target, not for CABG nor for PCI, because it's calcified diffusely until its apical portion. And the patient was rejected to CABG because in a heart team discussion, because she is, first of all, the LED is not a good target because it's diffusely calcified, as I have mentioned before. And the patient has a poor mobility. She walks with a walker. And as you can see, with a lot of comorbidities. And PCI will be complex here and high-risk PCI because of the calcium, the diffuse calcium in the LED. So we chose at that time to leave the patient on optimal medical therapy, wait and see. And we wait for 4 days, and the patient has recurrent chest pain, recurrent episodes of pulmonary edema. Though we could control well the blood pressure of the patient and the heart rate, and we decided to move to PCI, and our plan was to go with mechanical support. We have Impella in our center, but for financial issue, we couldn't use Impella because you need to fulfill some criteria in order to be financially support. That the patient a complex PCI with a shock, cardiogenic shock, or EF below 30, and the patient had neither of them. So we decided to do that with intra-aortic balloon pump, and we decided to plan to go with rotational atherectomy to LED, and if needed, intravascular lithotripsy. Here's the femoral approach, right femoral approach, and left femoral approach for intra-aortic balloon pump. All the punctures in our center are made mandatory, ultrasound guided. And here is the LED. And we try to inflate it to predilate in order to perform IVUS. But as you can see, a small balloon is not dilatable here in the proximal edge. And we decided to go with rotablation and then to perform the IVUS. So we have the floppy wire. We had the floppy wire, which is 0.20, and we need to replace it using a microcatheter or OTW. In this case, we used the over-the-wire balloon in order to replace it. Nowadays, we have that rotadrive wire, which is more torqueable, so there's no need for, in almost all the cases, no need for a microcatheter or OTW. And we have used it maybe first in Europe, Middle East, and Africa 2 months ago in our center, and the rotadrive is more torqueable. And it's the default for us for rotadrive wire. So we have the rota drive. Here we have the floppy one. So after a run of rotablation, rotational atherectomy, we have the bird to be stuck, entrapment. It was 1.5. And as we all know, there are several techniques in order to deal with entrapped rotabear wire. Rotabear, or trapped rotabear. The first one is simply to traction, manual traction of the rotabear, but this is the limitation, proximal vessel injury or shaft fracture, because we apply a high force. And you can go with wire if you have another axis with ping pong technique, wiring, going with a small balloon beside the rota bear and try to release the bear. And the last thing that you can do is to cut the system proximally and go with guide liner or child catheter and try to release, go as distally as you can and try to release the stuck rota bear. From these options, we tried three options. The first was a balloon. We cut the rota proximally, the rota system, and advanced the wire near the rota bear, and could go with the balloon but not reach the rota bear tip. So it was attempted only. And the second thing that we do, we take a guide liner in order to release the bear, but it was attempted only. And the last thing that we do, as you can see here, we pull the system, all the system out, including the catheter. I asked, when I pulled the system out, I asked my assistant to fix the femoral sheath because we apply a lot of force in order to take the system out. Unfortunately, the femoral sheath moved in and out, and we lost the right femoral approach. Then the patient at this time was stable, asymptomatic, and we know from previous CAT there is no, the left and right radial are occluded. From the diagnostic one, we go to through the right radial axis, but it was occluded after that, and the left is occluded previously. And the only axis that we have is the left femoral. We have the intra-aortic balloon there. So we change with exchange wire that was advanced near the balloon in the intra-aortic balloon sheath. Take all the intra-aortic balloon system out and replace it with the 9 French catheter. And at that time, we cannot tell if you have a complication in the right side, like a perforation, and it's life-threatening if we leave it. So when there is a doubt, you should look for it. You should look for this complication because it's life-threatening and gradually developing. So we crossed with LIMA catheter to the other side, and as you can see here, we have a perf in retroperitoneal oozing. We treat it with a covered stent, and was successfully done. These say the same thing. And then we go to the coronary artery and we shift to complete the coronary artery. And as you can see here, there is a coronary left main dissection as the previous, as we have seen previously. I left the wire in a plane of dissection, the first wire, and the second wire was advanced to through plane, then ballooning, and as you can see here, the proximal...
Dr. Haitham, I'm going to give you 60 seconds to close.
Okay, thank you. And as you can see here, the proximal part was undilatable, and we use IVL in intravascular lithotripsy in order to dilate it. Then we finish with stenting, and this was the result. And actually, if one asks how could we prevent rotablation bear entrapment, there are several things to do. First of all, to go with short movement backward and forward and slowly, and with a high RPM at the highest range. And the second is to choose the appropriate device, but here we wanted to choose IVL, but it's a bulky balloon, the IVL balloon, so we decided to go to rotablation.
Thank you, Dr. Haitham. I'm going to close your session and open it for questions. I have to stick with my guidelines.
Sorry.
Open for questions.
So tell me again the way you took the burr out. How did you do that?
How we take the bear out? Applying force.
You just but you
try
the wire and balloon along the side. You couldn't get the wire.
I tried a wire. Because of that, I have no access. I didn't go to ping pong technique, because if you want to apply a balloon near the rota system in 7 French catheter, you cannot actually do that until you cut the system proximally. So you have a place in order to pass with the balloon.
That's an important point, actually. So there are 2 advantages to cut it if you're really, really stuck. and especially since it's stuck in the middle of the artery. It's not close up there to where you can actually do your maneuver with the guider. If it was very proximal and you could carefully advance your guider and push your guider as you're pulling the burr, that is a bit dangerous. I've had to do it a couple of times, but it worked. Otherwise, you would have to do it with your, let's say, your guideliner or Godzilla.
That's what we tried, and it was only attempted. We couldn't reach deeply to
and typically middle of the artery, it's not going to track in the calcified artery that far down.
I think it's troubleshooting with a bar stack. First of all, the speed time. I think the speed time is very low, so you have to increase the speed time from beginning to avoid this kind of. So next time we have to increase the speed time 180 or something like this to avoid the stack. So this for prevention. So second, if we have this kind of bar stacked, because we have, of course, the center doing a lot of rotablator for this complex should be well equipped. So you have to have this heart rail from Tromo, mother and child techniques, which is, it's big than guideliners. And you cut the bar, you go there, you may also, if you have balloon undeflatable, we can cut it and they have some broken the balloon. But with the bar, you just cutting the bar, go with the mother and child techniques, go inside, and by this way, when you pull back the artery, the bar, it will not have a perforation. You are lucky that you don't have a big perforation, but it's well done. But when we are stuck and we decide to pull back all the system, we should know that we will have to pay. So the better to just get a heart rail inside. It is a 5 French, can go with 6 French, can go with 7 French, and you cut and you go there. Is better than guideliner or guidezilla.
Dr. Khalid, thank you very much for your comments. As much as I would like to continue this very energetic conversation, I have to close it. And I want to thank Dr. Shawley.
Thank you, everybody.
For being with us, and particularly that you're coming from my mother's hometown, Haifa. We welcome you in your second home in Amman. Ahlan wa sahlan bika min Palestine.
Thank you very much. Shukran للجميع. شكرا.
It's our pleasure to invite our dear colleague, Dr. Khalid تمام من المملكة العربية والسعودية. ويشرفنا وجودك معنا. Welcome, and we look forward for your presentation.
Thank
on
you.
LIMA complications.
Yeah, I'm actually Egyptian. I'm living in Saudi Arabia, so it's a pleasure to be here in Jordania and with my dear friends. Thanks for all organized committee to invite me here. However, it's not my area of interest. The LIMA, it's my area of interest is CTO. But Dr. Mahmoud wanted me to present some horror movie. So nobody allowed to have present this kind of complication, but as we are intervention, we should have this in our life 1 time, 2 times, depend on our luck. So I have a surgeon here, he will help me, but I will try to be quick with a message. So this is 67 years old male patient, has all risk factors, diabetic, hypertensive, obese. He has a previous cabbage coming with unstable angina, class 3, and he has a borderline LV function with a severe hypokinesia in the anterior wall. He had coronary angiography, which shows good circumflex with no significant lesion. RC is totally occluded, and he has a, why is not, so he has a SVG to RCA, which is very small. Okay, I'm here, sorry, it's, and he has this kind of LIMA, very tortuous LIMA with this lesion. We engage all through femoral, but when we engage the LIMA was difficult for engagement. Ventricularized ostial LIMA, and we said he has this type A lesion at the anastomosis side, but here, this tortious, it's always worrying us how to straight this artery, and maybe you have an accordion effect of the wires. So we go here, the wire is going easy, down, BMW, all slow, and then balloon dilatation went very smooth down, and then the stenting to pass this tortuous LIMA, it was very difficult. We try first stent, does not work. You see here, second stent does not work. Third stent does not work. But during this time, we have a severe chest pain, ST elevations in the anterior. Patient start to be sweating, and we inject here. Okay, here. Inject here. We don't have a LIMA. So, what do you think here? It's came in mind.
Pull the wire.
Pull the wire. We have an accordion effect. But if it's not accordion effect and he has a ostial, you lose disc patients. Yeah, and patient has so putting the wire to have it's came in mind when we have this tortuous accordion effect, no reflow because of the straightening the LIMA, playing with the LIMA, so it's coming in mind immediately. So I decided not to pull the wire, but I put a microcaster which is very soft inside the artery and I inject, same picture. I went with a balloon, same picture. So, and patient start to be collapsing, have a ST. I called my surgeon to come to help us to open the, but patient start to be on shock state. So what came in mind after I rule out that this not accordion wire effect from the wires, it's came in that maybe this has an ostial dissection, or ostial dissections, or in the loop from the stent, because the stent cannot pass. So maybe the loop, stenting is already dissecting the loop. So I have to fix or the ostial or the loop, but the stent cannot pass. How to pass the wire to the, again, other stent to close these dissections. So I make a decision to stent the proximal to see if this proximal dissection it's the cause of this no reflow. Again, is not, after I opened this one, was not flow again. I put another one, a small one here. Again, no reflow. We did all, we gave all the medications, adenosine, everything, adrenaline, all no reflow medications, not go. So it's some mechanical. So I try here to put a balloon after the second stent and the prolonged balloon and to see how is this artery behavior. If this dissection in this side, so we almost solve the problems. So I start to have some flow, and here's the dissection. This dissection, accordion wire effect here, I don't know. To be in safe side, I put the other stent. I know it's not second stent. Then I start to have a flow in the LIMA. So it was dissection. So I start to have the flow, patient hemodynamically improving, and patient start the ST depression, ST elevation start to subside, and I start to have some kind of pressure. So I film. So here there is another here, but here is, of course, I cannot put stent here. This may be spasm. So I try to do the original lesion for the patients, for other stent dystally in the anastomosis site. I put the stent, and then we start to have a good flow. LIMA is back. And here I have this kind of lesion. And this time, I put again the microcaster inside, this disappear. So by this, here is the accordion effect, not the first one. And then finally, after I move the wire, and I have here the LIMA bag. Sorry to put the big wire, but we save the patients without sending him again to bypass. And this complication may happen, I don't know, it's because of the torsions from beginning or from ostial dissection from the wire, I still not have a proper answer, but definitely it's something happen in the loop of the LIMA. So I can have time to have the second case. So it's all today's horrible about the LIMA. So it's again, it's a diabetic patient, hypertensive, dyslipidemic, end-stage renal disease, post-cabbage. He has some kind of anginal pectories, positive stress nuclear scan with ejection fraction of 40%. This was not my original case, but I have been called. He has been angio with one of our colleagues, and he has a very difficult peripheral vascular disease, and they spend a lot of time to engage the LIMA. But after they engage the LIMA, he has all the graft is fine, and when they engage the LIMA, they find this kind of thing. So almost thrombi from the caster to the LIMA. Again, patient start to be collapse. We don't know here, we don't have LIMA dystally. And the first one I have the anatomy, but this one I don't have the anatomy.
Is there a dissection in the LIMA?
Give agrostat, give heparin, we check the ACT. I could not have a good engagement from femoral. I went to the radial quickly, and I put the wire to stabilize, and I don't see the thrombus. The thrombus upstairs is not there, but it's migrate to distal artery. But again, here, your distal artery is very bad. I cannot see it. So what to do here, wiring here, the balloon 1.5 cannot pass this region. So here, until here, the balloon is stuck. So I went from antigrade, because I have some flow. I went with the wire. Again, the wire, as you see here, the behavior of the wire is not going as well. So he has some distal arteries, maybe occluded, disease. I could not pass the wire to the distal artery. So here, okay, 6 minutes, 6 seconds, okay, 4 seconds, it will kill me. So here it's, by manipulations, I get the artery, but actually the artery has a distal fistula.
If you can give us the conclusion quickly,
yeah,
please.
Yeah, quickly. Yeah, it says, I recanalize the artery, all the artery, and here it's all the LAD, but LAD is diffuse disease. I end up with just balloon, 2-0 balloon with drug-eluting balloon, and patient is doing fine. So the conclusion, LIMA, it's a complication is not so rare. It's happened once in a time, so we have to have the scales. We have to have a surgical backup with us as well as usual, and we have to have all the equipment to survive these patients, because sometimes his only remaining artery to survive this patient, and it's useless to lose this kind of LIMA. In this patient, particular patient, I want to open the native, but the LIMA is beautiful. I don't want to lose this kind of LIMA with this.
So what do you think, I mean, how do you think this clot got in there? Just from the injection? I mean, it was a poorly flushed catheter?
Yeah, maybe because the patient he get a long time to engage the LIMA. And he had not checked the ACT of the patient, post-dialysis patient. They have a lot of thrombi, dehydrated, and they are.
Back to the first case, if you allow me. I still think it's an accordion effect. We see it commonly in these type of situation where you have a full 360-degree loop. And in fact, what you may have done with the stent is straighten that loop. You see, so one thing that I would have done is to pull the wire back to the floppy part. I mean, I would still leave it across the loop, but pull it to the floppy part, because the microcatheter is still going to create the accordion effect. It is softer than the body of the wire, but it is not going to obviate.
So if we lost the LIMA, if we pull, because I have, like you, we have several accordion effect. All of the people working with the intervention, they have 100 of accordion effect, especially when you have 2-3 loops of LIMA.
Right.
But if this particular patient with shock state, and the patient has this kind of thing,
then you lose access completely.
And you lose everything.
Yeah.
Just, did you try before, when the stents were not getting in, did you try to get a heavy wire or second body wire? And
before what?
Before, when you were trying with the first stent.
As you were trying to get the stent.
Yeah, I was asking to change this with Grand Slam body wire to straight the LIMA, but the patient was collapsed before straightening.
Okay.
Nice case, Khalid, as expected. I think here's the place for the perfusion balloon and for the guide liner or for extension guide catheter. You maintain the flow and you go down and you go with the guide liner easily down, and even you can reach to the LED.
Yeah, it's
the stenting can start from there. You can start stenting and back.
Yeah.
Because you have very difficulty in getting the stents in.
You know, it's going with guide liners a little bit. It's again risky to dissect this kind of loops.
And plus,
so
it may not cross.
It cannot cross. Sometimes not crossing.
If the stents didn't cross, the guide liner is
you know, and I get a very low profile stent. I get a 10 size not working, Onyx not working, and all the new generation stent, which is short one, not big one, not long one. It's very short, as not passing. And after the third one, and we don't harm the LIMA. And after the third one, we get this kind of complication.
It is like climbing
excuse me,
just to go step by step.
Dr. Ryan, thank you very much. I have to stop this conversation, as interesting, as exciting it is, because we must move on. We're already 15 minutes behind. Dr. Khalid, thank you. The next speaker is Dr. Ahmad Sayyid.
Thank you for inviting me to this elegant meeting.
هاي وينك اليوم وصلت أحمد أنت؟ لو البارحة؟
نعم.
اليوم وصلت.
أول أمس.
الحمد لله على السلامة.
الله يسلمك. يعني I started from the beginning of this conference 3 years ago, and this is the third year. It's really growing and getting more interesting topics and cases. So today I'm going to present my case of Unraveled Stent. He was a 76 years old man. He is diabetic hypertensive, presented with anterior STEMI to a remote hospital. He was shifted to cath lab for primary PCI. That was the coronary angio. We appreciate a heavily calcified LAD and hazy thrombotic subtotal occlusion. Also, there is a CTO of the RCA with retrograde filling. The decision was made by the operator to go for direct stenting for this LAD He wired with a workhorse wire. And then multiple trials to deliver a stent, he couldn't because of the heavy calcification of the LAD. And then after that, we noticed that the stent was slipped inside the left main. The operator tried many times to, I don't know what he was trying to do. He was sometimes trying to retrieve the stent, or with a smaller balloon trying to go inside, but he couldn't. These were trials. He went with another wire inside the circ. Another balloon was trying to inflate distally and trap the stent and pull it back. Again in the LAD. Actually, after these trials, he lost the system. At that time, our team was called for help. That was the situation when we arrived. We found that a stent is stuck inside the LAD, inside the calcium in the proximal LAD, and unraveled inside the left main, and then the proximal part is protruding inside the aorta. So we have to put a plan. Our plan was not to injure the left main, because any manipulation to this stent to retrieve it, you could have a left main dissection and lose the patient. So we get a contralateral femoral axis. We went with 7 French guiding catheter, and we put 2 wires inside the LAD and the left circumflex to protect the vessel while snaring the stent. At that time, there were no snares at that cath lab, and also no IVAS. The third thing is, after that, to do proper lesion preparation before stenting. As long as there was no snare, we made handmade snare that was invented by Satoru Sumutsuji, snare, to go with the balloon inside the guiding over the wire, and then to flip the wire back and trap it with the same balloon. So you will have the monorail end of the wire free, so you can snare your object. Here we could grab the proximal part of the stent with the other guiding catheter after putting 2 wires inside the LAD and the left circumflex. Here is the second trick, is to lock the wire with the torque. Here we are pulling the wire so we catch the stent outside. So when I lose this wire, it will fill out. So I have to lock the wire with something, either a clamp or a torquer like this. That was also by Satoru himself. I get the idea from him. We couldn't retrieve the stent initially because of the first mistake we did. We didn't disengage the guiding from the left main. I think it went against snaring that stent. So this time we could snare that part from its middle, and then disengagement of the guiding catheter from the left main and pulling out the snared stent. And now out of the left main. We could retrieve it back. And then it went inside the femoral sheath. That was the stent after retrieval. we did a shot for the left main. Already there was no injury, no dissection of the left main. So we went for the rest of the procedure, pre-dilatation, proper pre-dilatation with multiple balloons and NC balloons. And then we went for stenting. We didn't we didn't stent the left main. Of course, we went with the small balloons, small stents overlapping the three stents. And that was the final result. Thank you.
Great.
شكرا جزيلا دكتور احمد. حقيقه طبعا انا لازم ادافع عنك لان انا ابني الان كارديولوجيست بيشتغل بمصر يعني فلازم ادافع عنك. العام بنفس الوقت كان كيس مالتك مميزه مال ليفت مين ستيم مضبوط صح ولا لا؟ العام الماضي هون نفس الشيء.
كان النوري فلو في الكوفيد.
يمكن. بس I would like to اليوم I would like to ask you why you decide to do direct stenting for this ugly lesion, heavily calcified lesion from the beginning.
It wasn't me.
مش انت.
لا.
So decision is that.
We went for extraction after the stent was lost. We were called for help.
So the message is that we should select the case and material and the plan from the beginning. This is the message for us. Thank you very much.
Any other questions?
Do we have?
Could you tell us again about how you did? Could you tell us again how do you do the handmade snaring technique? Because that's interesting.
The locked wire technique. Yes.
The balloon over the wire inside the guiding. It's a floppy wire outside the gun, and the balloon over the wire. It's a monorail balloon. And then you flip the wire back, the tip of the wire, the floppy wire, you flip it back and return it inside the guiding, and trap it with the same balloon. So now you will have the balloon inflated, trapping the tip of the wire, and then you can pull the wire from the end, from the free end outside, so it will retract and come back, because already the tip is trapped.
But you're trying, so you're creating a loop, right, with the two ends of the wire in the same guider.
Can you please?
فيكم ترجعوا تحطوا له الباوربوينت
ممكن
please.
slide.
Yeah. So you have a guider with.
Yes.
Yeah.
This one. It's a monorail balloon, the wire inside, and then flip the wire back inside the guiding, beside the balloon, and inflate the balloon.
And the balloon is in the guider.
Inside the
To
guiding.
trap the other limb of the wire.
Yes, the free limb of the
And
wire is
so,
trapped.
so you've created your snare basically, but what is the balloon doing? Because if you have a long wire with both ends exiting.
It's not the end exiting, just trapping the floppy end.
The floppy part.
Yeah.
The floppy part of the
Which
wire.
is the floppy part, which is the end of the loop.
Yes, it's like 10 millimeter only.
The problem.
Yeah, but you could use a long wire.
No,
but
the
long
regular
wire
wire.
has no
The regular
floppy.
180 wire or 190.
But why do you want it floppy?
Because the distal
No, it
part
makes
is hard.
sense, yeah.
The problem
it
with
will
this
make a
with this technique is the smart as a Satoru Samituji has been done this one a long time ago. But the problem it's sometimes it's very floppy, very soft, and if you can pull it, you can cut it inside, because this loop, this soft tip of the wire is always it's very soft one, and easy to be broken inside.
That's why in this case, I didn't trap only the soft tip. I trapped part of the hard tip just after the soft tip. So it will give me some force. The problem I face while advancing from the femoral, because I don't have the wire to reach the aorta, so I push the wire. Here, the soft tip is snared, so I push the wire, I make it as a rail for my guiding catheter.
Yeah, the best. Yeah, I understand. I do it several times.
The soft wire.
But I think it's the best to have a snare in our cath labs. Because this one, I know there's a cheaper one. We can have it, but the best to have but excellent you resolve
ما
it.
كانش في snare.
Yeah, I know.
Yeah, Dr. Ahmed.
Are saying another sitting was done.
Fantastic case. Thank you for sharing, Dr. Ahmed. I've learned a lot from your experience. Thank you so much for joining us. I think we're going to move directly into the next session because we are 15 minutes. Dr. Mahmoud gives us a thumbs up.